Hi, everybody. I'm Pat Wetzel, and welcome to All Things Cancer. I am really psyched. Today we have Dr. Leslie Schover here, and she's going to be talking about sex and cancer. Leslie has an incredible background. She's a two-time cancer survivor. She has a BA from Brown University and a PhD from UCLA. She's spent time on the staff of MD Anderson and at the Cleveland Clinic, and she's recently developed an amazing platform to deliver quality information and counseling to people anywhere in the world, really, on sex and cancer. So Leslie, welcome.
Well, thanks. Thanks, Pat. It's a great pleasure to be here.
Talk to me a little bit about how you came to specialize in this area.
Well, it was kind of by accident. You know, a lot of people end up specializing in cancer care because of a personal experience, but mine came very late in my life. So I already had been in the cancer center for many years before it was my turn. I actually, during my clinical psychology training, got interested in sex therapy, which was in its kind of infancy or early days then. And I did a postdoctoral fellowship with a psychologist who was doing research on how to make sex therapy more effective. And after that, I went to Houston for my first job and kind of hated where I was working, and got a call from urologist at MD Anderson that they were looking for a psychologist to come do research and clinical work about sexuality and cancer. And I thought, well, okay, I never really thought about that, but it sounds interesting. And it ended up being a great opportunity because in those days, if you talked to 100 people who had a certain kind of surgery about what was going on in their sex life, you were a pioneer because nobody had been asking people. So that ended up being the beginning of my career. And I was there for 5 years. And then I went to the Cleveland Clinic and stayed there for 13 years. And there I was the psychologist for the infertility program. And that kind of solidified my interest also in fertility and cancer. So Will to Love, my digital health company, actually covers both sex and fertility and cancer because they're kind of a natural fit together. And so after those years, I realized that really the part of my career that interested me most was still the cancer-related part. So I got an offer to come back to MD Anderson in 1999, and I spent the next 16 years there. And I just retired last January. It's almost a year now. And yeah, I've been spending the last several years putting together Will to Love, and we had support from several grants from the National Cancer Institute to develop. And then it's been a real transition to try to go from academic psychologist and clinician to entrepreneur. I still hesitate to call myself one of those.
Oh, I think you qualify at this point. Talk a little bit about Will to Love. What you've put together is really astonishing. It's going to touch so many people. Explain to our audience what Will to Love is, some of the services you offer, and some of the rationale behind it. I think you have some slides, and if you want to pull those up, feel free to do so.
Well, you know, my Will to Love slide is way at the end. So let me just say that if people are interested, you can go right anytime to willtolove.com. It's WILL, the number 2, and then love.com. And you'll see that we have a lot of free content. I've been doing a blog for the last couple of years, and we have forums for patients and healthcare professionals where you could post a story or get advice. We have a big resource section with lots of links to resources related to sex and fertility and advocacy groups. We are going to start monthly webinars soon, and I've been a little bit lazy in getting those started. And we also are just in the next couple of months going to be able to start our premium services. We have developed interactive online self-help programs for men and women that cover all cancer sites, sex and fertility. And they have things like, how has your type of cancer and treatment, how is it likely to damage or affect your sex life? What can you do to prevent or overcome problems with self-help strategies and with medical options? Also, how can you see other people's stories. Each of the programs has stories that are interviews of real survivors, and also some vignettes we did with actors to show some common situations and good and not so great communication. And so that is going to be available soon on a month-to-month subscription basis.
Now, a quick question. When should people get over to Will to Love? Because we were talking about this earlier before we started, the taping. Really, sexual problems exist throughout the cancer experience, not just at the end.
Right.
Is it important that people get information as soon as, early on in this process?
Well, it depends on their needs, and we've kind of tried to build Will to Love to satisfy needs from people who are newly diagnosed all the way down to long-term survivors. So there should be things there for everyone. But if you're trying to decide between 2 or 3 different kinds of cancer treatment that may have different consequences for sex or fertility, or if you're a younger person and you're considering freezing sperm or eggs or embryos before treatment, then it's very important to get that information quickly. But you can solve problems at any point. And one thing though is that if you know things when you're starting treatment, you may be able to prevent some of the damage. And so that's important. And I think people rarely get that kind of information from their oncology team. So that's something I have a strong interest in getting to people. And the other thing that we're going to start offering in a couple of months is telehealth counseling, either by a patient advocate or by an expert psychologist. And we're going to have to build our network of psychologists, because we're only allowed to counsel people, even with a video counseling platform, in the same state where we're licensed. And you can't, it would be very difficult to be licensed in more than a couple of states. So I'm calling on all my expert colleagues to come and join us, hopefully, and provide some services by video conferencing.
So somebody from the privacy of their home, they can hook up with a world-class psychologist and get that type of counseling. That's amazing.
And right now we're not accepting insurance, but because I just want to make this simple in the beginning, maybe later on we'll develop some contracts with big cancer centers or insurance companies. But my first goal is to just get this out to consumers. And, most people don't need 20 sessions of sex therapy. They need sometimes just 1 or 3 or 5 sessions to get on the right track, and especially with the help of our self-help programs, which they can use in between. So I'm hoping it'll be affordable for most people.
You have some slides. Do you want to pull those up?
Sure. Let me just share my screen here.
Okay.
Windows 10 always defeats me because I have to get back to my slideshow here.
It would defeat me too. I'm a Mac person these days.
Oh dear. Sorry, this should have been from the beginning, hopefully. Okay, there we go. Okay. Well, yeah, I thought it might help to have some slides to organize a little bit. Why is this important? Because certainly healthcare professionals are always asking me, well, why is that important?
Wait, stop right. Isn't that astonishing? What do you, I was talking to somebody the other day, and we were saying, what do you do if you bring this up with your doctor and he just closes you down? Then and it happens all the time.
It happens all the time. Then I think you say politely, I'm sorry you don't understand my problem. Can you refer me to someone who might have more information? Or failing that, you may have to do some of the legwork yourself to find referrals. And that's another reason I created Will to Love, because I was so frustrated after 35 years of my career, and people would always go, oh, that's such a nice talk. And then I would get, 2 referrals the next week and never hear from them again. And I just know that unless patients are proactive, most are not going to be lucky enough to have a team who really helps with these things. So I want to give 5 reasons why sex is important in cancer care. And the first one is that a lot of people don't realize, because we think only breast or only prostate, but actually a good 60%, and probably more like 2/3 of cancer survivors end up with long-term sexual problems. So that's right now about 9.3 million people just in the United States, and the situation is very similar in other industrialized countries with similar cancer treatments.
Are the problems mostly related to chemotherapy, to radiation, to both? Or what should people be aware of in terms of their treatments and how it can impact their sex lives?
Well, you know what, if with your permission, Pat, let me wait and get to that a little later, because I have some specific slides on that I think will be easier to explain. But you know, it's not just one thing. There are some treatments or some cancer sites that are higher risk than others. But you know, just think of cancer fatigue. If you can barely get up off the couch, are you going to feel like having sex? How many people suffer from that as they're going through and after their cancer treatment? So, or nausea or chronic pain. So those non-specific things also affect sex, not just the direct damage from treatment. The other thing that really gets me upset is how few people get any professional help for these sexual problems. So the best statistics I can find are fewer than 20%. And not surprisingly, when they do surveys of cancer survivors and ask what are your unmet needs, sex just consistently ranks among the top 5 unmet needs, not surprisingly. And there's no one oncology profession, whether it's psychologists, nurses, oncologists, social workers, that really takes responsibility for discussing sexual issues. And so I call sex the hot potato of patient healthcare provider communication, because nobody wants to do it, which is really a shame, because it's so rewarding when you do learn a little bit and help people. And what healthcare providers call talking about sex is like, are you going to be able to have a hard erection? Are you, if you're a woman, going to be able to have a penis in your vagina? And that's not what patients mean when they say, I want to know about my sex life. They want to know, am I going to be lovable? Are people still going to be attracted to me? Will I still be able to have pleasure and orgasms? A much broader array of things that they would like to discuss. And for many people, at least during cancer and sometimes afterwards, a key issue on staying sexually active is not defining sex in our cultural script of foreplay, penetration, and afterwards, which even for many gay people is still their preferred way of having sex, but accepting that sex is a sharing of all kinds of intimacy and pleasurable touch, and it doesn't necessarily always have a goal like simultaneous orgasms.
You know, Diane Mapes up at Fred Hutchinson wrote a series of articles on sex and cancer. They were terrific. I don't know if you had a chance to see them, but I pulled her short quote because she just absolutely nails it. Let me just read this. I'd love your reaction.
Sure.
Cancer cuts us to our sexual quick. Men may struggle with impotence, women may lose their natural lubrication, and most everybody's joy button is off, thanks to the psychological, emotional, and/or physiological changes wrought by diagnosis and treatment. It's hard to feel sexy when you're suddenly wearing surgical drains or a colostomy bag, or your prostate meds have given you man boobs. And then there's that whole death thing.
Yeah, that's very nice. Yeah, it does kind of summarize it from A to Z there.
Yeah, it's, you know, you've lost body parts in many cases. Body image is a huge issue for people. It's astonishing that nobody really talks about this. And that's one of the reasons why I really want to get your platform in front of people, because I think it provides information that is just sorely needed. Sorely needed.
Well, not only that, but there's a misconception, especially among health professionals, that this is all psychological, and cancer treatment directly damages the systems that are often needed to experience a good sex life. And we'll talk a little bit about that. So body image is very important, but beyond that, it's not just body image, but it's physical damage. So another reason why it's important is that in study after study, people who have sexual problems are also more depressed and more likely to report a poor quality of life. And of course, we don't know what's the chicken and what's the egg. And it may be just that people who are sicker because of their cancer have all these things together. But I also think that it's very disheartening to lose an important part of your self-concept and your relationship.
Well, and it also, as you know, going through cancer, there are a lot of divorces, breakups, et cetera. That is not an uncommon thing to have happen. And that just raises the ante even more in terms of stress and depression.
Although, you know, there are a number of studies that suggest that the rate of divorce is not that much higher after cancer, if at all.
Mm-hmm.
And it is higher. The sad thing is it's higher when the woman is the cancer patient. And I think part of that is because society does not train and accustom men for the caregiving role. So I think men are more likely to be anxious and cut and run when they have to assume more of the caregiving functions in a relationship, especially when the woman is really, really ill. But there's something of a myth in a way that there's a lot of divorces after cancer. I think with dating relationships, they tend to be more fragile. And for young people who go through infertility, that I think can be a factor in the breakup of some relationships. But a lot of it is, what was your relationship like when you were diagnosed? And I realized early on that I could kind of tell which relationships were going to be in trouble and which couples were going to report they felt closer to each other, because it depended on their coping skills and the quality of their communication and bond with each other.
What are some of the barriers to getting help?
Well, one thing is just, we all know how little time you have with your oncologist and even the nurses and social workers when you go to a clinic. And are you assertive enough to bring up sex if they don't? Because most of the time they don't. And unfortunately, with all we're hearing about value-based care, I think most cancer centers and insurers still don't have sex and fertility very much on their radar screen. And so insurance coverage for these services is poor. Most people cannot get insurance for their fertility preservation. And also, if you have couple counseling or sex therapy, your mental health policy in the fine print may exclude those services from what they normally cover. And they'll say it wasn't mental health or substance abuse. Well, all these things are diagnoses in the diagnostic manuals, but they manage to wiggle out of it anyway.
Oh.
Also, did you have a comment, Pat?
No, just wow. I'm just stunned. And I'm particularly stunned at the fertility treatments possibly not being covered.
Well, you know, that's an issue with all infertility treatment in the United States. Insurers have been able to get away with the idea that infertility is not a medical condition. Can you believe that? So Congress has not had the resolution, and with all that's been going on the last few years, to really pass major legislation. There are a few things for veterans that have passed recently, but for the general public, no. Also, women expect their gynecologists to be their sex doctors, and very few gynecologists actually have any training or experience in treating sexual problems or even menopause symptoms. They're surgeons and OBs, and women are often very disappointed with the care that they get. Urologists have had, in the last 20 years since Viagra and similar medications have come on the market, more of a training and willingness to prescribe different treatments for ED, as erectile dysfunction, so erection problems. But a lot of the treatments don't work nearly as well as promised in the TV commercials, and urologists are also surgeons, and they often don't have a lot of patience with men, having them come back regularly and fine-tune the treatments or try a different treatment if pills don't work. So a lot of men try pills in particular and give up on them because they don't work very well for most men after really serious cancer treatments. And even when it comes to counseling, very few mental health professionals have a lot of training in how to treat sexual problems or in how to treat cancer patients. So finding someone who has both kinds of expertise is rare, and that's another reason why I want to offer those telehealth services through Will to Love.
No, that's actually a really interesting point, because there is virtually no counseling available to people going through cancer, just the whole cancer experience. It's very hard to find people who are well versed in that. There are several books that people put out that are helpful, but to actually find somebody to speak with is difficult. And then if you layer the sexual piece on top of it, where do you go? How do you even find a referral?
Well, for one thing, I would point out that there are some wonderful organizations like Cancer Care, which serves the New York area, but also nationally through phone and online, and also the cancer support community.
Okay.
And they offer free services, and I really admire them. And the American Psychosocial Oncology Society has a referral line, but what is a lot more difficult to find are the specialists who really have the sex and cancer piece. So we have a few people listed on our website, but even most cancer centers, the big ones, I think there are only something like 6 that have a clinic that treats sexual problems, and they're, what you would expect, like Memorial Sloan Kettering or Dana-Farber. And people who get treated in their local community don't have those kinds of resources. So it is difficult. Another point I'd just make, my 5th point, is that sexual issues, as we touched on, don't just affect newly diagnosed or long-term survivors, and oncologists are often, oh, let's delay that, we'll talk about that when you're done with your treatment. But actually, there are sexual issues at every point in treatment. So from being newly diagnosed and wondering which treatment is going to be the least damaging, to trying to stay sexually active when you're feeling miserable and going through active treatment, making that transition to survivorship at the end of treatment, and finding your new normal, and how do you even have a sex life again, and then sometimes dealing with late effects, like, for example, a lot of survivors of childhood or teen cancer end up having really bad hormonal problems later in life, but prematurely compared to where you would expect, not in their 60s, but in their 40s. And even when people have a recurrence or are dealing with advanced disease, intimacy and sometimes orgasms and sexual touch are very important to them, and even in end-of-life care. So this is something that affects people at all stages of the journey, not just in the beginning or just at the end. And I did want to say a little bit more, although we could go on for hours about this, about what is that specific damage I was talking about that cancer treatments do in men and women. Well, for one thing, these problems tend to be severe. So you might have lost desire for sex, have trouble getting an erection, have trouble feeling pleasure when you're touched on your penis, have trouble reaching an orgasm because you don't have an erection and you're not sure how to reach an orgasm with a soft penis, and even have pain. And so these aren't just one problem, they're often interconnected problems, and they unfortunately rarely go away without some treatment. And as I said, very few people see a healthcare professional. So for women, anything that puts women into a sudden premature menopause, and that could be chemotherapy damaging the ovaries, radiation aimed at the pelvis that damages the ovaries, taking medicines that shut down the ovaries like Lupron, and taking some of the or having both ovaries removed. All of those can cause premature menopause, and the symptoms that come with that are severe vaginal dryness, a lot of hot flashes for many women, which disturb sleep and make you tired, and having a lot of vaginal dryness that causes pain when you try to have caressing on the vulva or penetration inside the vagina. And women who have hormone therapy for breast cancer are a very common treatment, especially the aromatase inhibitors, which are now the preferred treatment, they take away whatever little bit of estrogen your body still makes, like in fat cells and other places. So if you had some dryness with menopause and then they put you on those meds, then a lot of women have such severe pain that they give up on sex altogether.
Is medically induced menopause more severe than a natural menopause?
It's often, the symptoms are often more severe, and if women stay in menopause for a longer period of time, like if women have chemotherapy in their early 40s, then they have 10 more years of menopause, and gradually all the changes mount up over time. So it is a problem. And then, of course, women with breast cancer, or some women with endometrial or ovarian cancer, are advised not to take estrogen, so they can't counter those symptoms. Whereas a young woman who has lymphoma, for example, and maybe has chemo in her late 30s and is thrown into menopause, should be on estrogen replacement until the normal age of menopause, which is around 50 or 51. So both will stay strong.
That brings up an interesting point too. Who do you, within your medical team, who do you talk to about these things? Because your oncologist probably isn't going to know. Maybe your gynecologist will know. I mean, who do you talk to try to coordinate this?
Well, with some of these things, your oncologist should know. And if your oncologist doesn't bring it up, then you need to be assertive and say, hey, wait a minute. What about osteoporosis? What about vaginal dryness? What about premature changes in the brain without estrogen? What are my risks and benefits in taking hormone replacement? And if you don't know, then send me to a gynecologist who does, because not all gynecologists are going to have expertise in this area. For example, at MD Anderson, where I spent so many years, we have what we call our benign gynecologists, and there are about 4 or 5 of them, and they're wonderful, and they actually treat the reproductive side effects of cancer treatment.
Wow.
So finding someone like that is really, really a blessing. Another problem is any radiation that includes the ovaries is going to usually destroy the ovaries forever and cause infertility. And also radiation that includes the vagina or the vulva, like chemoradiation for anal cancers, can be just devastating to women's sex lives and men's. Or adding radiation therapy as an adjunct when you have rectal cancer treatment. Or radiation for ovarian cancer. All of these add even more risk of sexual problems, not only because of the loss of estrogen, but because of direct damage to the delicate lining of the vagina, and sometimes radiation ulcers that are hard to heal. And the vagina loses some of its ability to stretch with sexual arousal and loses its ability to produce lubrication. So these are really major problems that women often are not warned about enough. And you can prevent some of that damage by using vaginal dilators, or starting really early to use estrogen if you can, or if not, vaginal moisturizers and lubricants, so that you don't start this cycle of sex being horribly painful. Also, women who have transplants, stem cell or bone marrow transplants from a donor, can sometimes get what we call I'm having a senior moment, graft versus host disease, graft versus host syndrome. And that's when your body actually reacts to the donor cells as a foreigner and starts fighting against them and creating all kinds of symptoms. And especially nowadays when women have stem cell transplants and take colony stimulating factors, at least a quarter of them have GVHD in the vagina and on the vulva, and you have to catch it really quickly. It starts often with vulvar redness and pain, and if you don't do anything, you get dense scar tissue that'll actually close up the vagina, and it can be treated with local estrogen cream and local creams that work to reduce the immune reaction. So that's really important. And again, a lot of women aren't warned what to look for and to come in and get treatment. And a lot of women end up with incontinence of urine or stool. Like, we talk about the difficulties of ostomies, but at least you can usually control an ostomy pretty well and keep yourself odor free and keep your bag out of the way. But if you've had radiation and you're having diarrhea 20 times a day, and you have problems with incontinence during sex, a lot of women give up on sex because they feel so embarrassed and ashamed, and that's rarely talked about, and what to do or how to deal with that. So that's something that we also talk about in our interventions. And for men, one of the things I always like this idea of unrealistic expectations, especially with prostate cancer, because the radiation therapists and surgeons have been fighting each other for years to say, we have the least damaging treatment, and now they have all these other treatments like HIFU and cryotherapy, and every treatment when it first comes out, they go, oh, we have no erection problems after this treatment. And every time, after several years and a wider variety of patients who get treated, it turns out that the great majority of men end up with erection problems. So you get a lot of really angry men who are told, oh, you'll be in the 80% who don't have a problem, and it's really the 20% who don't have a problem. So after treatment for prostate or bladder or rectal cancer, even in those men who start out with good erections, and at least a third or 40% of men in that age group already have erection problems, only a quarter of them recover anything like the erections they had before their treatment. And it doesn't matter if you have surgery with a robot and a laparoscopy, you might lose less blood and spend less time in the hospital, but it does nothing better for your sex life. And unfortunately, they've been trying to, minimize damage from radiation therapy with all these different treatments that use computers to design fields and try to get less radiation damage to the surrounding tissues around the prostate. But the long-term results suggest that they all have very high rates of erection problems. It just happens more slowly and over time, whereas after surgery, your erections are worse soon after and then may recover some. With radiation, they just keep getting worse and worse over the years. So, and along with the erection problems, which are what men focus on, often comes loss of desire, trouble reaching orgasm, having dry orgasms without any semen that may not feel as pleasurable. Again, like women, having urinary or bowel incontinence or pain during sex. So these are things that rarely get discussed or treated. And even after more systemic cancers, like men who have intensive chemotherapy for leukemia or lymphoma, or people who have bone marrow transplants and have total body irradiation or intensive chemotherapy, a lot of men end up with temporary or permanent problems with their hormones that don't get tested for, even though they are very treatable. And it looks like men with testicular cancer often end up with less sexual activity and lower desire, although there are some conflicting results about that. And then we talk about our successes with children treated for cancer, how 75 or 80% survive their cancer, which is wonderful, but they also end up with a lot of long-term late effects. And at least a third of young adults who were treated for cancer have sexual problems, and they're similar to the kinds of problems that adults have: erection problems, loss of desire, pain and vaginal dryness for women. A lot of young women don't get the hormone replacement they should be getting because nobody is paying attention. And when you're treated as a child and then you finally go through puberty, or sometimes they need hormones to go through puberty, people often are not paying good attention to the state of these systems that you need to have a good sex life, much less the problems with infertility, which probably affect at least half of childhood and young adult survivors. So they have a third to a half fewer children than their siblings do. And they can do these studies in Scandinavia, where they have cancer registries and birth registries, and they can match them up and look at over millions of people in 20 or 30 years, how many people have children. So, one of the things I think that's really cool now, and the thing that really started me 17 years ago now on this path, is that once you have information online, it's there 24/7, and I don't have to go through the oncologist or the oncology nurse or social worker. I can go directly to people and say, look, here is accurate information. Here is me on a website as best I can do. And if you are able to navigate through some simple websites and have adequate skills to read, then it's there for you. And if some of those things are a problem, like if you have a visual impairment or you're not at all computer literate, then a patient advocate could help you, get through these sites. So at Will to Love, as I described, we have our free website that has our blogs, forums, resources, and we'll soon have our webinars. And then we have our male and female self-help programs. And we hope to soon have some trained patient advocates to help people for a small fee. And basically our telehealth services. So let me stop the screen sharing, because that's the end of my slides, and go back to just talking.
Well, I'm learning so much, and I don't think any of us, when we get a cancer diagnosis, are aware of the massive ramifications.
Actually, it was really funny. I'll tell a bad story on myself. I've been divorced for 17 years now, and I don't think I've gone on a date in that entire time. I've just ignored that whole part of my life. And of course, when I was diagnosed, I was treated by all my friends and colleagues in, the breast clinic and GYN, and they're all making so sure to tell me, about the sexual issues. They want to get their brownie points for doing it right. And I felt so bad, like, you're wasting your time on me. I'm sorry. So much for physician heal thyself, or psychologist heal thyself.
So anybody, the platform's up, it's running, the self-help pieces are functional. People can go there today at their convenience and start getting some information on any sort of problems they may be having, and hook up with a live person to talk to them.
Well, that's probably going to be true around February or March. We're still waiting for our insurance to come through, and I need to train our advocates and therapists before we're quite ready to do that.
Okay.
So we're getting very close but our free content is all up there, our blogs and our resources, and so that's there right away.
And
which I hope more people will use.
And hopefully the oncology profession, radiologists, et cetera, are going to learn about Will to Love and start sending patients that way.
I hope so. And we also have a part of the site that we're just finishing that isn't visible to the public right now, called our Pro Portal, which is actually for healthcare professionals. And it includes a special website that includes skills training, like some of the tips that I use in workshops for healthcare professionals on how to be more comfortable and effective in talking to patients about sex. And then we have a really detailed clinician manual for how a clinician, like an oncology nurse or a patient advocate or a psychologist, could work with the patient using our self-help programs, but giving them a little bit more direction and supplemental counseling. So I'm hoping to elevate the quality of the care that people receive, even if they don't receive it from our Will to Love clinicians on the website. I'm hoping that we'll get a lot of patient advocates and oncology nurses and navigators out there who will have access to that and will have a much deeper pool of knowledge to resource, because they're the people that are doing the frontline counseling, and they have often the best will in the world. But what's out there now on the internet is, I have to say, it's 50 miles wide and a millimeter deep, very repetitive, and not a lot of practical information on how to really change things.
Are you going to be at ASCO this year?
No, I don't think I'll be at ASCO this year. I have a bad habit of only going when I'm invited to talk. And now that I'm no longer in my academic position, I probably am going to have fewer of those speaking invitations. And maybe by next year we'll have a booth and we'll exhibit. But I wasn't quite ready this year.
Yeah, no, next year will be great because certainly that's another good way to get word out. And it's such an interesting confluence of people.
Yeah, and they have been wonderful at having me give some invited talks and meet the professor things in the past. So
what would you want to leave people with in terms of advice, advice and guidance on how to take charge of the sexual piece of the cancer experience?
Well, I think the first thing I would say is realize that you are probably going to need to be your own advocate, because unless you're very lucky, your oncology team is probably only going to tell you enough to pass the informed consent requirement. Like I once had a talk to urologists and I said, the 5-second informed consent on sex after radical prostatectomy is, Mr. Jones, after this surgery, your sex life is over. And although I think they're a little bit better these days, it wasn't so far from the truth back then. So if you want more information, you may have to say, look, this is really important to me. And either if you can help me, that would be great. If you can't, can you direct me to someone who can? And if you're having trouble finding resources, hopefully some of the links on Will to Love will be of help to you. And very soon, I hope we'll have our full range of services available.
Everybody, will2love.com, love.com. Please check it out. Put it on your bookmark list because the site is growing and expanding, and it is an amazing resource. I don't think we've ever had anything quite like this available to so many, and I think it's going to help many, many people all over. Leslie, I'm just so impressed by what you're doing, and I'm so grateful you were able to come today.
Oh, thank you. I'm really glad to have this forum to reach out to people, and I love working with you. Pat is on our board, and so we're really happy to have her guidance.
Well, everybody, we're going to sign off. Thank you very, very much. Leslie Schover, will2love.com, and we'll see you next week at our usual All Things Cancer. Thank you. Bye-bye.